Go ahead and get started again. Hopefully we'll go a little bit slowly enough so that Tony can be fully on board before we launch, but we can introduce other folks. So we're back for our policy roundtable. I want to thank those of you who are new to the roundtable, but just to point out that we still have with us Dr. Stephen Lamberti and Dr. Vinod Srihari, who have been part of the conversation so far, as well as Arun Nagendra and Mark Pomper, two people with perspectives from the patient community. So we are now welcoming Kristen Khalaf, excuse me if I'm completely mispronouncing your name, Gillard. Would you like to introduce yourself, please?
Sure. Hi, everyone. Kristen Gillard from representing Karuna Therapeutics. I lead the health economics and outcomes research function within the organization. Nice to be here.
Thank you. We at ICER love people who have HEOR attached to their name. As you know, you're part of a special tribe, and we welcome you to this conference. Thank you. And who's next? I'm going to wait on Tony at least for a second, but let me introduce Marina Saman. Again, apologies if I'm getting your name incorrectly, but please introduce yourself.
Sure. Hi, that was perfect. So I'm Marina Saman. I'm a clinical director on the Payer and Provider Insights team at IPD Analytics. So I'm a pharmacist by training with a background of over 20 years of experience working for large national payers. And one of my primary areas of focus at IPD is behavioral health. So happy to be here.
So you have both a kind of a clinical background, almost one could say, a pharmacy background. And we really appreciate having representatives from IPD Analytics on these roundtables, because I think of you guys as, in some ways, as a whisperer to the payer community. You hear, you think, you listen to what they are doing. You give some advice, obviously, mainly by sharing what others are thinking. But you have a broad view of what coverage issues look like across different types of payers in the fragmented U.S. healthcare system. So it's really helpful to have you here, and thank you for doing so. And then Tony Grillo, if he is with us, let me see, I'm looking and I'm not seeing him back yet. So we will get to Tony in a second. I know Tony, he's a PharmD, and he's been a vice president at Express Scripts for a while. He, I have his exact role because I've known him for so long, but he's deeply involved in setting policy within Express Scripts, which is one of the very largest pharmacy benefit managers in the country. Obviously, they're linked to Cigna insurance company these days. And he's had a very wide role kind of overseeing specialty pharmacy, clinical operations, drug trend, and formulary management. So he's a great person to have at the table. And I'm sure we will do everything we can to get him back into the meeting. But let's go ahead and start. So where we're headed, though, you can take down the slide now. Thanks. Where we're headed in this discussion is to build on the conversation from this morning and try to forecast the future. What is the future going to look like? How do we need to put the pieces together around future research, coverage, pricing, broader clinical supports and training? How can we identify and promote the steps that all stakeholders can take to try to make the world a better place for people living with schizophrenia and their families, given the introduction of a new treatment like KarXT, which we are going to assume, for the sake of certainly this roundtable, that it will be approved and will come into practice later this year. So one of the first questions I like to ask before we jump into the weeds of coverage and pricing is just the bigger question of, let's again assume that doing this right means addressing explicitly the issues of health equity, access to the right treatments by broad populations, many who have been perhaps underserved or discriminated against in different ways. What needs to change? What needs to happen as we think about KarXT coming into practice that would improve that situation, make it better? And feel free to say, well, it would take them over there, those other people, to do something different. All right, Arun, you spend your life thinking about what other people should do in the healthcare system, right? To get this right. I think you have followed that good mandate of the public speaking, where I think you've hit your theme very clearly and very distinctly. It's access. So how do we make the system work with access to a new drug like KarXT? What has to be right?
Oh my gosh. Well, I think like a huge part of the issue is the kind of absolutely fragmented nature of care and the many settings across which people with schizophrenia dwell. So, some people with schizophrenia are in kind of like living independently in the community, but many of them are homeless. Many of them are incarcerated. Many of them are in assisted living facilities. And like there needs to be a way to actually get care to those folks. I think another issue is like the idea of insight or anosognosia, like the inability to see that you have an illness, I think is a really critical thing to consider because it's a huge part of the reason people with schizophrenia do not actually take their medications. And I think that the fact that there are just not enough like trained providers, not enough places to seek care, not enough provider education, there's a high levels of provider stigma, and there aren't kind of like they're not enough kind of like integrated care systems and places for people with schizophrenia to get care. So, I mean, among our suggestions are very much like funding interventions to increase early detection of schizophrenia and connection to care, making
All right,
sure.
whoa. I want to capture each of these, not only with a what, but the who. All right, so who needs to take what action to accomplish that outcome? Is it Congress? Is it CMS? Well, who does that?
I don't know that I have the answers to that. I would say a lot of this does need to come from Congress in terms of funding for these integrated systems of care that we very much believe in. But we do think there need to be these kind of like federal level changes because a huge part of the issue is that the way that care is delivered and kind of insurance coverage and access to treatment and the availability of treatment varies so much from state to state, county to county, city to city, that it feels kind of like this gargantuan task to actually get care to everybody who needs it.
Can I just pause? Do you have any specific problems with one branch of insurance in this way or one provider type? I mean, it could be that things are okay in Medicaid, but they fall apart if they get into a private insurance company or vice versa. I mean, anything from your perspective, again, that would help us identify specific actors who need to change or do something new.
I would say that this is just given that the majority of people with schizophrenia are on Medicare, like that would be a place to focus. But beyond that, I think it is not just a private insurance or a public insurance issue. It's just that I think people just have trouble getting care, but that's not my area of specialization. Sure.
Okay. I'm going to turn to the clinical experts in a second to get your views on this too. But Mark, I'm wondering, oh, you have your hand up. Perfect. Because I was going to say either you and or your wife in your conversations, do you guys have a to-do list for people?
I know we've got a very long to-do list, but I was going to say that in our own experience, I was fortunate to work for a number of companies that were very good to me in terms of giving me private medical insurance and extending it beyond the time my son was 26. They let me continue to keep under care. But what I found was kind of counterintuitively that as nice as it was to have high quality insurers behind us, the approach tended to be as soon as the patient is stabilized, out the door they go. And unfortunately, this is a kind of illness which really does require long-term treatment and care and supervision, and it's just not there. So I would say that so ultimately we moved him to Medicaid, not because they're better. It tends to limit his treatment options on the outside. There are very few psychiatrists that are willing to take Medicaid, but on the other hand, this stays in hospital. There's not the same rush out the door. So I would say that in terms of reform, there really needs to be, I would love to see Medicaid, Medicare take a really strong look at, large populations, which obviously they serve, and do some statistical work on different kind of medications that are potentially available, including new ones, and sort of run trials that would sort of, create, you got a captive pool. And there obviously also you could extend this into the